Welcome to today's featured research spotlight featuring ADAA's 2021 Donald F. Klein Early Career Investigator Award winner, Annamarie MacNamara. The annual Klein Early Career Investigator Award is presented for the best original research paper on neurobiology, psychopharmacology, psychosocial treatments, or experimental psychopathology of anxiety disorders and depression. This award is named for Donald F. Klein, who revolutionized psychiatric thinking. We would like to welcome the 2021 virtual conference Donald F. Klein awardee, Dr. Annamarie MacNamara, who will present on her research. Dr. MacNamara is a clinical affective neuroscientist who uses fMRI and EEG to examine emotion generation and regulation across the internalizing psychopathology spectrum. Consistent with the mission of ADAA, Dr. MacNamara's long-term goal is to reduce the suffering and cost associated with emotional disorders by bringing diagnosis and treatment more in line with underlying pathophysiology. Thank you so much for joining us, Dr. MacNamara.
Hi, my name is Annamarie MacNamara. I'm an assistant professor in the Department of Psychological and Brain Sciences at Texas A&M University. Today I'll be talking to you about some of our recent work that has sought to identify a brain profile that might explain comorbidity load and worse outcomes in the anxiety disorders. So first I'm going to talk to you about the general issue of anxiety and comorbidity load, move on to some prior work looking at neurobiological variability along an anxiety spectrum that might explain increased comorbidity load and worse severity and outcomes in the anxiety disorders. Then I'm going to talk to you about the candidate brain profile that we have identified that seems to track comorbidity load. And then I'll wrap up with our future directions. So the current diagnostic system emphasizes discrete categories. We know that this may not map on to underlying dimensions of psychopathology. So there's been increasing evidence of this. One example of this, or symptom of how it may not exactly map on to underlying dimensions of psychopathology, is the levels of comorbidity. So comorbidity is the norm in the psychiatric disorders and particularly in anxiety disorders. 50% or more of people have an additional diagnosis or two. So it's very common for people to have multiple diagnoses. As a clinician, this should mean something to me. So if someone comes into my office and they tell me that they have multiple disorders or I diagnose them and I find that out, this should be indicative of how they're doing right now and how they're likely to do in the future. And the news is not good, unfortunately. So this individual with more diagnoses is more likely to have high levels of disability, increased use of medical services, higher risk of suicide. If they get treatment, they're going to take longer to get well. If they get well, they're more likely to relapse. So this is an unfortunate picture of events that should mean something to me as a clinician. And yet I don't know what to do with this information. So I have no way of treating their comorbidity load. I don't have different treatments or different levels of treatment for them. We treat in a piecemeal fashion. So I am likely to treat their most disturbing disorder first, hope that effects will generalize, perhaps move on to another one from there, that sort of approach. There is confusion amongst clinicians. I would argue that we don't know whether these multiple disorders are multiple variations of the same thing or in fact discrete disorders that require different treatments. And so maybe if we had a better understanding of the mechanisms underlying comorbidity load, we could work to target treatments specifically for these patients who are most in need. One alternative to the diagnostic system in terms of thinking about these individuals with multiple diagnoses is to think more about an anxiety spectrum. This idea has been supported by genetic and epidemiological work, and that spectrum might look something like this. So individuals with relatively focal fear, low levels of comorbidity, and low negative affectivity, that's the tendency to experience high levels of chronic negative emotion, so that being relatively low, those individuals might fall at the low end of the spectrum. On the other end of the spectrum, we might have individuals with relatively diffuse anxiety, high levels of comorbidity, and high levels of negative affectivity. Neurobiological work has sought to track this spectrum or explain its correlates in terms of biological activations. And the temperament literature has done this by looking at negative affectivity. So negative affectivity is very strongly predictive of internalizing psychopathology. It is also associated with increased response to negative stimuli in brain regions associated with threat processing. This includes the amygdala, the anterior insula, anterior hippocampus, and many other regions, but most of the work has focused on the salience network. This is comprised of the anterior cingulate cortex, the amygdala, and the insula. And most work looking at these regions associated with threat processing and anxiety has really come together to suggest that the salience network shows increased activation and heightened connectivity as we move along a spectrum of increasing negative affectivity. There is some evidence to think that this increased engagement of threat neurocircuitry might be causally related to anxiety. Neurons in the central amygdala are both necessary and sufficient to elicit increased defensive behaviors like freezing. Stimulation of insula inputs into the amygdala produce anxiety-related behaviors like freezing. And monkeys with amygdala lesions show reductions in threat-elicited defensive and endocrine response. So we have some evidence from animal work that there is a causal relationship between these brain regions and defensive responses similar to anxiety. We also know that connections between the insula and the amygdala are necessary for avoidance of unpleasant stimuli and elevated anxiety. And we also know that putatively distinct anxiety disorders and depression share the same neural signature, which we have been terming exaggerated alarm. So this tends to be activation and connectivity in the amygdala and the insula in particular during negative emotion provocation. So on the right here at the top, you can see the results of a study that we did in a large sample of individuals with mixed anxiety and depressive disorders. And what we found was that anxiety scores across these different diagnoses correlated with activation to negative faces, so angry faces, in the insula. So the more anxious patients reported that they were, it showed heightened activation in the insula to angry faces. This is again irrespective of primary diagnosis, which you can see plotted there in terms of social anxiety, generalized anxiety, and major depressive disorder. At the bottom, we have results from the meta-analysis, which found that multiple disorders, multiple anxiety disorders, including PTSD, social anxiety, specific phobia, and also fear elicitation in healthy individuals, all looked relatively similar in terms of engagement of insula and amygdala. So from that body of work that I've just presented, which is largely fMRI and some animal work, we have an indication that as we move along this anxiety spectrum, we might see evidence of increased engagement of threat neurocircuitry. I'm going to move now to a different literature, which is the EEG literature. And here we get a complementary perspective on this. So it tells a somewhat different story, but I think one that, when put with the amygdala insula findings, can tell us a more complete picture of what this spectrum looks like. So the component that I'll be talking about today is the late positive potential, or the LPP. This is an event-related potential that is elicited by salient stimuli, including emotional stimuli. So if we look on the right, I'm first going to point out to you that positive is plotted downwards. So here we see that unpleasant pictures depicted in the solid black line elicit a larger LPP, more positive amplitudes than neutral pictures, which are depicted in the dashed black line. We can see the distribution of these amplitudes on the scalp in the head map. So the LPP is largest at central parietal regions. Again, it is larger for emotional stimuli compared to neutral stimuli. It's thought to measure the elaborated processing of stimulus salience. It receives contributions from a variety of neural generators, including the amygdala, regions of the prefrontal cortex, and also visual cortex, particularly when visual stimuli are used to elicit the LPP. So it provides a balance of bottom-up and top-down inputs into how salient a stimulus is, and it's thought to measure the prolonged, elaborated processing of stimuli. And what prior research has shown using the LPP across this anxiety spectrum is first that increased LPPs, too negative compared to neutral stimuli, are observed in relatively focal, non-comorbid anxiety disorders. But as we move along the spectrum to the other end, we find that the LPP becomes blunted in individuals with more diffuse anxiety, higher levels of NA, and higher levels of comorbidity. I'm going to show you some of this prior work. This first example is of heightened LPPs in the relatively focal low end of that spectrum. So here we have undergraduates, and we're looking at their panic symptoms. So panic would be a relatively focal fear. And again, these are undergraduates, so perhaps not that extreme in terms of their panic symptomatology, relatively functional, we would think. Amongst those individuals, those with this higher focal fear, higher levels of panic, show heightened LPPs to threatening versus neutral stimuli when compared to those with lower levels of panic. These findings were continuous. They are simply depicted here in terms of groups to illustrate the results. We also see this larger LPP amongst individuals with higher levels of state anxiety. So that's depicted in part A of this figure. So we see as individuals have higher levels of state anxiety, they have larger LPPs to aversive versus neutral targets. And then in a separate sample, we found also that individuals with generalized anxiety disorder show larger LPPs to negative versus neutral stimuli. I want to point out here that this sample on the right was collected prior to NIMH's Research Domain Criteria RDoC initiative. And so this was back in the day when we chose people that had a pure diagnosis of GAD, meaning they had no comorbidities. They did not have depression. We worked really hard to get this sample. It's very hard to find many individuals with GAD that do not have depression. We had to screen out a lot of people, but that was what we did back in the day. And so the point of telling you that is that I actually think that although they had a diffuse diagnosis, generalized anxiety, I do think of them as relatively low on that spectrum because that is the only diagnosis they had. And so they were non-comorbid and they had, in a sense, a relatively focal disorder. And so here we see in this relatively focal version of GAD, increased LPPs to negative versus neutral stimuli. But when we throw depression in the mix, we see a somewhat different story. So in this other sample, we see again that individuals with GAD show larger LPPs to unpleasant or threatening stimuli. But amongst individuals with either MDD or those comorbid for MDD and GAD, we see a blunted LPP. So again, this fits with the spectrum idea in that as we move towards that more diffuse, more debilitating, more comorbid end of the spectrum, we see a blunted LPP to negative stimuli. We've also seen this in a youth sample. So in this sample, individuals, youth, had either anxiety disorders or we had healthy controls. And so these were mixed anxiety disorders. When we compare the patient group to the controls, we see that the anxiety disordered group is associated with larger LPPs to fearful faces and angry faces when compared to shapes. So again, this supports the idea that there's a component of anxiety, a relatively focal anxiety, that's associated with increased LPPs to negative stimuli. But if we look across the sample, we see that as depression increased, we see a blunting of the LPP. So we also see that within the same sample, those who are further along the spectrum are actually showing a reduction in the LPP. So again, this maps on to that anxiety spectrum idea. Although we are not recruiting these samples specifically to test that idea, it does support the idea of a heightened LPP that moves to a more blunted LPP along that spectrum. This is recent work from my lab in which we used an imagery paradigm. So here individuals listened to an audio description of a negative or a neutral scenario, and then they were asked to imagine that scenario for 10 seconds following the offset of the audio description. So there's only a fixation cross on screen. This is entirely the imagery they are generating in their mind, either negative or neutral. We can get a nice LPP to that. And what we see is that those with no depression show a robust LPP. They show large amplitudes to negative scenarios that they are imagining. That's depicted in the solid red line in the waveforms. But we see that individuals who have depression have a much smaller LPP to negative scenarios that they are imagining. That's depicted in the dashed red line. You can also see these findings in the heads. So we have individuals with no depression on the left, and they have an LPP to negative imagined scenarios, but those on the right have depression, and they do not show that same LPP to the negative scenarios. We found that categorically, that is diagnostically, that's what I just showed you on the left here, but if you look on the right, we see that we also see those same findings depicted in terms of continuous associations with depressive symptoms. So here we see that as individuals become more depressed, they have a smaller LPP to negative imagery. So again, this maps onto that anxiety spectrum notion. I want to point out here that although I've shown you some findings involving depression, we are not sure yet that this is about depression. So that's something that we're still trying to tease out. But we do have some evidence that we see blunting in other disorders as well. So this is in PTSD. Here we have individuals with PTSD showing a smaller LPP, a blunted LPP, to angry faces versus shapes when compared to combat-exposed controls. These were veterans with or without PTSD, so matched for levels of combat exposure. We see that blunting in the PTSD group. We would expect these veterans with PTSD to be relatively far along that spectrum, and fitting with that, they show blunted LPPs to negative faces. We have some suggestion also that this blunted LPP might be prognostic. So here we have individuals who completed 12 weeks of cognitive behavioral therapy for anxiety or depressive disorders, and they completed a picture viewing task at baseline. And so this is the LPP predicting how they did in treatment 12 weeks later. And what you can see is that those with more treatment gain showed a larger LPP at baseline. We see that blunted LPP at baseline predicting worse treatment outcome. So again, this maps onto the idea that perhaps this spectrum explains some of the phenomena that we see in more comorbid individuals, which includes worse outcomes with treatment. All right, so let me sum up what we've been talking about so far. We have emerging evidence of an anxiety spectrum. That spectrum looks something like this: low levels of comorbidity, relatively focal fear, low negative affectivity at one end of that spectrum. Moving to the other end, we see diffuse anxiety, high levels of comorbidity, and high levels of negative affectivity. We've also shown that when mapping that spectrum in terms of neurobiology, we observe increased salience network activity and connectivity at the high end of the spectrum, but we also see a blunted LPP to negative stimuli. And so in putting this literature together and trying to understand how we could use these complementary methods to really target and get at the nature of comorbidity load in anxiety, we have been thinking that perhaps this is one explanation. So maybe this combination of a reduced LPP with heightened salience network activity could actually be a problem, could actually signal combination of alarm with heightened alarm with attenuated higher order processing that could otherwise be used to modify threat appraisals. So we know from the exposure literature that to reduce fear, we need sustained engagement with threatening stimuli to really bring about changes in that fear structure. If we don't have that, and yet we have this heightened alarm, this might portend worse outcomes. And so it could be that heightened alarm and reduced motivated attention, which we are referring to as harm A, might be one mechanism by which anxiety is maintained and worsens over time for some individuals. We sought to test this hypothesis in MyK Award data, funded by NIMH, for which we are grateful. And this sample had 78 individuals. We recruited these individuals to have a common focal fear diagnosis so that there was some similarity among them, and yet they were allowed to vary on number of comorbidities. We recruited them into two different comorbidity groups to ensure range on comorbidity load. So we had a low comorbid group, which had that focal fear diagnosis plus 0 or 1 other diagnoses. And then we had a high comorbid group, which had the focal fear diagnoses plus 2 or more other diagnoses. We wanted individuals to have that focal fear diagnosis to ensure commonality despite the fluctuating or the variation in comorbidity load. We didn't want to confound those factors. You can see on the right the number of diagnoses in those two groups, including the focal fear diagnosis. All of these individuals performed a passive picture viewing task with negative and neutral pictures in the scanner, and again in a separate EEG session. And here are our results. So these are the group results first. We found that individuals who were more comorbid showed greater engagement of the salience network. You can see here that those who have high levels of comorbidity show heightened amygdala activation to negative versus neutral stimuli compared to those with low levels of comorbidity. We also see this for the anterior insula, though not depicted here. We also found that this high comorbid group had smaller LPPs. So the low comorbid group is on the top here. You can see a robust LPP to negative versus neutral stimuli. And the high comorbid group is on the bottom. Negative stimuli are depicted in red, neutral stimuli are depicted in black. And you can see that particularly during the later part of the LPP, from about 3,000 milliseconds onwards, more comorbid individuals show a blunted LPP to negative stimuli, much smaller amplitudes. You can see that waveform going right up, showing blunted response. You can also see this depicted in heads, We have a nice red head for the low comorbid group and a much attenuated LPP in the head for the high comorbid group. So again, blunting amongst those who are more comorbid for the LPP. And finally, we get to the real question of interest here. So what we really wanted to ask was whether this combination of heightened alarm and reduced motivated attention might portend worse severity for these individuals. And so we used a regression analysis, we used an interaction term, meaning that we were looking at how the combination of amygdala activation and LPP went together to predict internalizing psychopathology. This was a regression with main effects of amygdala and LPP entered, as well as the interaction between amygdala and LPP. We used this to predict latent internalizing psychopathology derived using principal components analysis across multiple self-report measures. And we found that the interaction did map on to internalizing psychopathology in the expected direction. So what we see here is divided into groups of participants simply to illustrate the results. Analyses were continuous. This is a high amygdala, low LPP group, so individuals with this harm A profile, heightened alarm, reduced motivated attention. And we see that these individuals have high levels of internalizing psychopathology. What we see here are individuals with low levels of amygdala activation and small LPPs or low LPPs. And we see that they do not have very high levels of psychopathology. Here we see those with low levels of amygdala activation and high, large LPPs. These individuals have some internalizing psychopathology, but not that high. And finally, we have those with both heightened alarm and high levels of motivated attention, large LPPs. And these individuals also do not have very high levels of psychopathology. And so we see that it's really that group with high levels of harm A, heightened alarm, and reduced motivated attention that has the highest levels of internalizing psychopathology. We also defined harm A in a different way, or rather defined alarm within harm A in a different way. So here we are examining amygdala-insula connectivity. So here we ran the same regression analyses, but with amygdala-insula connectivity interacting with the LPP, again controlling for main effects, and we get similar results. So those with high levels of alarm and small LPPs show high levels of internalizing psychopathology. We do not see that for any of the other groups. Again, this analysis was continuous, but I'm illustrating it here using groups. So further evidence that heightened harm A seems to be associated with high levels of internalizing psychopathology. We were also interested in knowing whether this combination of heightened alarm and reduced motivated attention might be associated with historical comorbidity load. If indeed it was, this would support the idea that perhaps this brain profile and internalizing psychopathology are reciprocally related, such that bouts of psychopathology might leave a scar in terms of heightened harm A, which then might put individuals at future risk for more psychopathology, which then might put them at future risk for more harm A, and so forth. So that this would explain the downward trajectory or spiral of some individuals as they acquire more and more diagnoses. So here we divided individuals into those who had high levels of past comorbidity, multiple prior diagnoses, versus those with low levels of historical comorbidity load. And we used a logistic regression, controlling for main effects, including current number of diagnoses, to predict past diagnoses, being high or low. And we see here that harm A again predicts high levels of historical comorbidity load. So on the right, we have high levels of amygdala activation, and in the red line, we have small LPPs or low LPPs. And we see that that combination of a small LPP and high levels of amygdala activation is associated with a greater chance of having had a high level of historical comorbidity load. So again, these individuals with high levels of harm A do seem to also be the ones that had a lot of prior psychopathology. Finally, we were able to follow up with some of these individuals 18 months later to see critically whether harm A predicts future psychopathology. And so here we found that individuals with high levels of harm A show greater dysphoria at time 2, controlling for baseline dysphoria at time 1, as well as main effects of amygdala and the LPP. We can see on the right side of each of these graphs high levels of amygdala activation, and we can see the red line is depicting low LPPs or small LPPs. Time to dysphoria is on the y-axis. So you can see that those individuals on the right side of each graph with lots of amygdala activation and a small LPP in the red line are those that are most likely to show high levels of time to dysphoria, controlling for time 1 dysphoria. So it would seem that harm-A predicts increase in dysphoria 18 months later. Finally, we were also interested in looking at some mechanisms that might explain this link between harm-A and psychopathology. So what could it be about this brain profile and an individual's experience in the world that leads to worse outcomes? To do this, we looked at how harm-A moderates the association between stress and negative affect. So stress and negative affect are associated, perceived stress, but if you look at that according to whether someone has high or low levels of harm-A, what we find is that those with high levels of harm-A show the strongest association between stress and negative affect, suggesting that if you have a brain profile associated with harm-A and you encounter stressful events, you're more likely to translate that into high levels of negative affect than someone that does not have that brain profile. So in sum, we are considering the possibility that harm-A, heightened alarm, reduced motivated attention, might be a neurobiological pattern associated with comorbidity load. It could be a unifying mechanism by which anxiety is maintained and worsens over time. Our working model is a reciprocal one, illustrated in the bottom right here, conceptually, suggesting that harm-A portends greater future psychopathology, but also that psychopathology gives rise to increased harm-A, which sets up this downward spiral whereby some individuals acquire more and more diagnoses with increased severity over time and less chance of remission. Going forward, we are grateful to NIMH to be able to continue this work in a longitudinal fashion, to really be able to look at these associations over time in multiple time points, rather than cross-sectionally with one follow-up. I'm thankful to my graduate students, Elizabeth Bauer, Kayla Wilson, and NIMH for supporting this work. Thank you for your attention.
Thank you, Dr. MacNamara. Don't miss updates and application information about ADAA's 2022 awards program. Applications open June 2021. If you are not yet an ADAA member, please visit adaa.org to learn about our many member benefits. Thank you so much for watching. We hope you have a wonderful day.